Good afternoon, everyone, and welcome to the third day of the Cleveland Clinic and Ohio Clinicians for Climate Actions, Climate and Health Activate, Educate, Implement Symposium. All live events are going to be recorded so you can review the Q&A sessions after. They will be on the OCCA YouTube page beginning next week. This symposium is a Learn at Your Own Pace symposium. All the pre-recorded sessions are available on Whova and can be watched at your convenience in the video gallery. During these live events, we will watch the pre-recorded session and be joined after by the speakers for a Q&A. This afternoon, we will hear from Dr. Kasia Rothenberg as she details the impacts climate change has on mental health. We will also watch Drs. Ilyssa Gordon and Sophia Asphal speak about hospital resiliency in the labs and in surgery. For the QA portion this afternoon, we will be joined by Dr. Gordon, who will be able to answer specific questions regarding the labs. A general reminder, please remain muted throughout the duration of the session. If you have questions, please utilize the chat box. At the end of the presentations, I will populate a link to a survey in the chat box for this afternoon's live session. We invite everyone to complete the survey as it provides the symposium hosts and speakers with valuable feedback. Nurses, if you would like CNEs, you must complete the survey. Once submitted, a link will appear and you will be able to print your CNE certificate. Physicians, directions on how to obtain CMEs are in the syllabus located in the Documents section on Whova. Without any further ado, let me share my screen and we will begin with our first video.
Welcome everyone. A couple of words of introduction. My name is Kasia Rothenberg. I'm a neuropsychiatrist representing Cleveland Clinic and specifically Center for Brain Health. I have nothing to disclose for this talk. And today I would like to focus your attention on climate change and mental health. I will present to you a concept of climate change induced chain of events leading to mental health symptoms. We will review some data. I will give you a couple of examples. We will talk about populations particularly vulnerable to those phenomena. We will discuss as well something interesting, psychiatric syndromes specifically related to climate change. And I hope to save a couple of minutes for other considerations. Climate change is unquestionable fact, and more evidence is being gathered about its negative influence on human health. In 2016, US Global Change Research Program, the graph comes from this report, released the consensus opinion that climate change impacts not only medical and physical health, but mental and even community health. This is relatively new knowledge. Most of the data that we had so far is coming from the analysis of psychiatric symptoms in the context of climate change related natural disasters. All natural disasters, biologic, geophysical, and last but not least, hydrometeorologic, influence mental health. I don't need to remind you that we are living in the time of pandemic, classic biological, natural disaster. We are all aware, of course, of pandemic influence on our mental health. One type of those phenomena, hydrometeorologic, represented by flood, storm, extreme temperature, heat waves, cold waves, drought, and wildfire, could be specifically related to climate change. And hydrometeorologic natural disasters are definitely on the rise. In this graph, which I found in New England Journal of Medicine, hydrometeorologic disasters are represented by blue bars, which are definitely on the rise, much more than the brown bars, geophysical disasters. Follows this rise. We should be talking then about climate change initiated a chain of events leading from global phenomena through economic hardship, lack of resources, lack of resilience, declining health. This is an interesting study I found in Science. In 2009, researchers looked into global warming. Global warming per se, it is an obvious phenomenon. We know that future summers would be much warmer than ever, but it leads to hunger. And because of that, the magnitude of hunger will be on the rise. We would expect that a population of people who experience hunger will double. Hunger leads to lack of resilience and declining health. Another example, flooding due to rising seas, flooding due to heavy precipitation, frequent heat waves, all are linked to economic damage, lack of resources, hardship, and deteriorating health, including mental health. Let's move closer to mental health outcomes. Let me give you a couple of examples based on data from relatively recent studies. Prevalence of all those listed here, sensu stricto psychiatric symptoms, had been rising during and after hydrometeorologic disasters. PTSD and depressions are the ones most studied. Let me start, however, with acute stress disorder. Acute stress disorder typically presents within 4 weeks of an extreme traumatic event. Dissociative symptoms of acute stress disorder are similar to PTSD and consist of sense of numbing, detachment, altered sense of reality, depersonalization, and dissociative amnesia. In the aftermath of Hurricane Katrina, researchers found that 62% of the evacuees met the criteria for a diagnosis of acute stress disorder. Many times, acute stress disorder evolves to post-traumatic stress disorder. This phenomenon is the most frequently studied psychiatric outcome of climate-related disasters. It is characterized by flashbacks, avoidance of stimuli specifically associated with trauma, hypervigilance, and sleep disturbance. PTSD prevalence ranges from 30 to 40% across different disasters among those directly involved in them. One study from 2007, Katrina population, so population affected by Hurricane Katrina, the prevalence was almost 31% in terms of PTSD symptoms. Another type of natural hydrometeorologic disaster, Fernandez and colleagues found a greater incidence of PTSD among victims of extreme flooding than in the general population. Impact of wildfires. Marshall and colleagues, this is a 2007 study, reported that 24% of those affected by a wildfire in California showed symptoms of PTSD, and the symptoms persisted. They were present in majority of the victims at 3-month follow-up. Let's go back to Hurricane Katrina. Very well-designed study which looked into population of New Orleans before and after hurricane. This group of researchers was interested specifically in serious mental illness. And now what they found, significant increase in across the board serious mental illnesses by 89%. Huge increase. Let's look at a split. Depression increased by 33%, PTSD similarly to previous studies by 32%, and very striking finding, suicidality increased by almost 62%, even though depression only by half of it. And again, the same population was looked into after a couple of months, and the symptoms tended to persist, which means definitely lower resilience. Depression. Depression is the second most commonly studied mental health outcome among survivors of natural disasters. Just to remind you, the symptoms of depression include feeling sad or empty, loss of interest, feelings of worthlessness, inappropriate guilt, changes in sleep, changes in appetite, and difficulty concentrating. A lot of smaller and bigger studies go back in terms of depression and natural disaster, analyze Katrina population, but here I wanted to quote for you a study of the mental health outcomes after wildfires. Very, very vivid and important to us currently subject. And they found that 33% of participants of the study exposed to wildfires met the criteria for a probable major depressive disorder. It's definitely not that high in any population. So significant influence of natural disaster. And last but not least, anxiety. Once again, Fernandez and colleagues analyzing people exposed to flooding noticed that exposure to this type of natural disaster correlates with higher level of anxiety, and symptoms included excessive worrying, restlessness, irritability, fatigue, difficulty concentrating, muscle tension, sleep disturbance, panic, and phobias. Let's put everything in sequence. Let's visualize the chain of events. Many effects of a climate change, such as extreme heat and violent weather, can harm people's mental health and well-being. Extreme weather, floods, and fires can threaten, damage, or destroy people and their homes, communities, loved ones, and social network. The threat, damage, and destruction caused by climate change can cause increased anxiety and depression in many people, especially children, older adults, and low-income Americans. I already started a segue to vulnerable populations. The quoted before US Global Health Research Program analyzed existing data and came to consensus that certain populations are especially vulnerable to natural disasters. And first of the list, displaced people and forced migrants. Second on the list, extremely important to our topic, people with pre-existing mental or physical health conditions. Next one on the list, people of lower socioeconomic status. Many times that means community of color. Fourth on the list, children and young adults, and last but not least, elderly, older adults. So far, we had been talking about classic psychiatric symptoms in the context of climate change-related natural disasters. A decade ago, however, interesting observation came to play from Australia. Glenn Albrecht and his team, he's a philosopher in Australia, studied population of people exposed to extreme drought and fires, which led to loss of their livelihood. And he noticed this interesting psychoerotic distress syndrome consisting of hopelessness, anger, sadness, and discomfort. He named it, he coined the term for this syndrome. He called it solastalgia, from solatium, which means comfort, and the Greek root algia, meaning pain. For last decade, solastalgia had been noticed, studied, and has become a central concept in the analysis of a cultural, personal, and mental health risks posed by changing climate. Another interesting term, which of course describes certain situation. It was even mentioned by American Psychiatric Association. It's not a formal diagnosis, it's just a noticeable syndrome, eco-anxiety. Eco-anxiety was defined as a chronic fear of environmental doom. Now, interesting feature of this particular syndrome is that people who experience it are not necessarily involved in natural disasters. They are not necessarily exposed to it. So even knowledge about changing climate, knowledge about how climate may influence our lives, knowledge about the chain, this climate-related chain of events, it's enough to cause this syndrome, of course, in vulnerable people. To this point that climate change-related phenomena are considered as on a list of those things which people look into when they start a family, when they buy houses, when they move to certain areas, etc., etc., etc. Sometimes very limiting, sometimes extremely anxiety provoking, sometimes eco-anxiety needs treatment. I wanted to pause for a while and segue towards a little bit more positive observations. So a couple of thoughts on a positive note. I wanted to mention to everyone that I am glad that awareness of a climate change and mental health is rising. I present to you 2 pages from internet pages. There is organization, the movement of a name Climate and Mind, and another organization of a name Climate Psychiatry Alliance. Both gather a lot of specialists, psychologists, psychiatrists, therapists, a lot of discussion, a lot of data, sharing opinions, a lot of awareness. Here in Cleveland Clinic, we have as well environmental sustainability professional staff engagement program, which I belong to. And because of this interest, more and more studies are being designed to look into, once again, positive side of nature, how nature influences positively our health, especially mental health. And I present to you here a review of 11 big studies, which together would include almost 800 participants, which was showing us data to support the statement that exercise in nature, interacting with nature, has a great effect, much more prominent than other type of exercise on our well-being, especially mental well-being. On the same note, I don't know how many of us are aware of something which is called forest bathing. This term and movement came to us from Japan. Shinrin-yoku means exactly forest bathing. And what does it mean? They looked into population of people even once exposed to relaxation in nature, in the forestry areas, as opposed to populations of people resting or relaxing in different setting. And huge impact, much better outcomes in all kinds of outcomes measures, especially influence on mood, improving mood in those even once exposed to forest bathing. And I will pause now, open the floor for discussion, and leave you with, with Shinrin-yoku and its good influence on both physical and mental health. Thank you.
My name is Ilyssa Gordon. I'm Associate Professor of Pathology and Medical Director for Sustainability at the Cleveland Clinic. And today I'm going to talk to you about hospital resilience as it relates to the laboratory. The learning objectives for my talk are to identify opportunities for resiliency within the hospital laboratory setting, and to discuss strategies to reduce resource overutilization in the hospital laboratory. First, we need to define what we mean by resilience. Resilience is the ability to recover from or resist being affected by a shock to the system. In this talk, I will describe the major systems that are essential for running a laboratory and the ways that laboratories can be prepared to recover from and resist being affected by a shock or disruption to the system. Hospital laboratories contribute to overall energy consumption, carbon footprint, regulated medical waste, landfill waste, chemical and solvent waste, and water use of the hospital. So there are many opportunities to prepare for disruption. First, we're going to talk about energy. One thing that I want to point out is that of the 10% of greenhouse gas emissions that the healthcare sector contributes to total US greenhouse gas emissions, about 36% of that is attributable to the generation of supplied power. Hospital labs are in use up to 24 hours per day. Lighting, heating, ventilation, and air conditioning, or HVAC, refrigerators and freezers, and many other pieces of equipment must remain on at all times. At the Cleveland Clinic, we run about 2,000 different kinds of tests. So many different types of equipment and analyzers are needed to be maintained and ready to use. And if the refrigerators or freezers can't stay on, specimens needing testing will be lost. If the ventilation system isn't working, our ability to perform sterile testing will be lost. In this overview of the microbiology laboratory space, you can see all of these energy-consuming systems that the lab relies on to function. I'll let you take a moment to see if you can identify as many as you can on your own before I point some of the ones that I see out to you. So hopefully you saw lighting, and these here are some ducts for the heating, ventilation, and air conditioning system that controls the ambient temperature in the room. Over here is a door and a window which closes off our sterile room, which requires its own specialized ventilation. Here and here we have special refrigerators and incubators for cold storage and for heating and incubation of specimens. Here in the front we have testing equipment. We also have computers, monitors, and printers. Disruptions in energy can occur at multiple levels, and the lab needs to be prepared to handle each one. If a single freezer breaks down, is there a plan in place for prioritizing frozen specimens? What needs to be saved first? If a single piece of equipment short circuits, is there any backup equipment? Is there send-out capacity for that test? Establishing partnerships with other laboratories, both reference laboratories and neighboring hospital laboratories, is an important component of being prepared. If power to one floor of the lab building or the whole lab building goes out, we need to have backup power. Usually, this consists of generators, which can keep the lab running. If power to the whole hospital or the whole city goes out, we need to have a backup plan. It is essential to prepare in advance for these possibilities. While these opportunities for resilience planning related to energy use in the labs may seem remote, there are benefits to reducing energy use in the laboratory that can help decrease the lab's carbon footprint and decrease demand on the energy grid. At the Cleveland Clinic, many of our clinical labs are housed in in a LEED certified building, but this is not the case for the majority of hospital labs around the country. Most labs have to work within the constraints of the existing building design when considering energy efficient improvements to reduce the carbon footprint of the laboratory. This requires working together with a multidisciplinary team, including the hospital sustainability manager, engineering, buildings and design professionals, lab directors, and lab managers. Regarding lighting, automatic occupancy lighting sensors can be installed so that lights in less used areas aren't left on when not in use. Regarding HVAC, air exchanges for sterile areas should be optimized to the current standards. Many pieces of laboratory equipment, including freezers, biologic safety cabinets, and fume hoods, consume energy to some extent even when not in use. Capital purchases of equipment do not usually take into account or emphasize energy efficiency in most laboratory settings. However, identifying equipment that can be turned off at the end of a shift or at the end of each day without affecting the test validation process is a good option. Also, shutting the sash on fume hoods when not in use saves energy. Think of it like closing your car windows when you have the air conditioning on. My colleague Ken Kula in our medical art department created these graphics for me, which illustrate some of the points about closing the fume hood sash, which you can see here. And about turning off equipment we may not be using, which you can see here. We've covered energy. Next, we'll take a look at supply chain. Because the laboratory is running 24 hours a day, supplies are needed 24 hours a day. Space is needed to store appropriate on-hand supplies, And we need all of the various supplies needed to run those 2,000 different kinds of tests. Commonly, when thinking of laboratories, people think of chemicals, which yes, we do use. We need to maintain key reagents in stock in order to reliably run tests. Beyond the blood vials and specimen cups that any consumer of healthcare may be familiar with, within the lab we have many more kits, vials, racks, and other items that we need to keep in stock. Finally, incubators for specimens like blood cultures need to be supplied with specified ranges of gases to maintain the appropriate atmosphere. Also, liquid nitrogen is used for flash freezing of tissues. So there are quite a variety of supplies that the lab relies on to function. As we've learned from the current pandemic, supply chain shortages do happen and do affect laboratory testing. The CDC and Department of Health and Human Services recently released this notice to providers about shortages of test kits and laboratory supplies for testing of sexually transmitted infections, affecting multiple companies and impacting several components of the specimen collection and testing process. Let's take another look at the same overview of the microbiology laboratory space I showed earlier. Now, I'd like you to take a look and see all of the products and supplies that you can find that the lab relies on to function. I'll give you a moment to do that. We can see durable goods like desks, chairs, monitors, and equipment. Reusable goods like lab coats, racks, bins, and single-use item like reagent containers, specimen and sample containers, plates, and tubes. As with energy, disruptions in supply chains can occur at multiple levels, and the lab needs to be prepared to handle each one. If a lab runs out of a testing kit for a test that is run daily, be sure there's a plan in place for communicating to ordering providers and establish prioritization of testing to best utilize remaining stock until new stock arrives. Is there a different test that could be run to answer the same question, such as a molecular test instead of an immunohistochemical test? Is there send-out capacity for that test? Once again, this is where our partnerships with other laboratories are key to have in place. What if supply of a reagent or collection tube is short at the manufacturer level? We need to have prepared communication pathways to receive One way to be prepared to handle disruptions to the system is to consider reduction strategies for the use of supplies. Can a reusable item be used instead of a disposable item? Do you recycle solvents in your laboratory? Have you taken a look at chemical use in your laboratory protocols to try to reduce or minimize use of various chemicals? Have you looked at water use in protocols and washing procedures? Also, workflow optimization can help limit supply use. I want to take a minute to let you know about pathologists. Pathologists are the medical directors of hospital laboratories. We create budgets, we approve capital purchases of new equipment, we perform and oversee procedures, and determine testing schedules, how many runs per shift, per day, and per week, and we ensure staffing is maintained by qualified laboratory technicians. To pathologists, the laboratory technicians are equivalent to nurses. Nearly all hospital inpatient encounters and many outpatient encounters utilize the hospital laboratory services. Keep in mind, what happens in the hospital labs affects all physicians and most patients, not just pathologists. Reducing overutilization of resources in the laboratories contributes to hospital resilience, cost savings, and a healthier environment. In these last few slides, I wanted to let you know about some additional aspects of laboratory resilience, looking outside our laboratory walls. Some laboratory supply companies are already starting to look closely at their manufacturing processes for opportunities to reduce the carbon footprint or energy intensity of production and for resource reduction to better withstand supply chain fluctuations. Given that we're in the midst of hurricane season, I also wanted to share with you this lab management article from 2018 about laboratory resilience related to hurricane preparedness, but which can certainly apply to other large-scale natural disasters, such as wildfires and flooding that different parts of the country experience. Many of the points that the author makes here are similar to what we've already discussed. In addition, she highlights the need for strategic generator placement. Put it on the roof rather than the basement to avoid flooding. She also talks about the use of point-of-care testing, which is laboratory testing done outside of the laboratory space, as well as having a recovery plan. Importantly, communication and the need to plan in advance are also emphasized. And finally, looking ahead to technology that can help with our resilience efforts, where pathologists are really looking to the future. The concept of when there are no roads can be applied to rural areas, but also extreme weather events, and when roads may be flooded or communities may be cut off from hospital access due to closing of roads from fires or hurricanes. This article discusses the opportunities for drone use in sample transport related to road closures. In conclusion, opportunities for resiliency in the laboratory have been discussed, as well as strategies to reduce resource overutilization. We talked about these concepts as they relate to energy and laboratory supplies and the supply chain. The key takeaway I'd like you to have based on this lecture is to plan in advance. Thank you, and I'll be happy to take any questions during the Q&A time.
Thank you for the opportunity to present. I have nothing to disclose, and the views and opinions presented here are my own. Today, I hope we understand the effects of climate change on public health, understand the effects of climate change on surgery in particular, understand the contributions of healthcare facilities to climate change, and propose solutions to increasing healthcare sustainability in operating room environments. When we think of conditions or actions that have been collectively affecting public and population health, diseases like obesity, smoking, heart disease, recently COVID-19 and others come to mind. Attention has, in some fashion, recently focused on climate change and its negative effects on public health, but the spotlight is not bright enough. Evidence links lung cancers, other respiratory and cardiac problems, gastrointestinal, vector-borne illnesses, waterborne illnesses, allergies, and other diseases to fossil fuels and climate change. According to Lancet, climate change is the biggest global health threat of the 21st century. The impacts will be felt all around the world, not just in some distant future, but in our lifetimes and those of our children. Action on climate change is imperative to preserve human life. Every year, an estimated 12.6 million people die as a result of living or working in an unhealthy environment. Environmental risk factors such as air, water, and soil pollution, chemical exposures, climate change, and UV radiation contribute to more than 100 types of diseases or injuries. And over the past 3 decades, national asthma rates have more than doubled. Areas of Northeast Ohio are designated by the US EPA as non-attainment zones. The Northeast Ohio area ranked the 11th worst over 200 metropolitan areas nationwide for year-round particle air pollution. In Cleveland, this pollution can often be visible, which is shown here as a haze over the city is captured by the haze cam run by Dr. Sumita Khatri, Cleveland Clinic pulmonologist in the Respiratory Institute. As we know, climate change can lead to extreme weather events. The events caused by climate change have not only caused significant damage to buildings and infrastructure through direct impacts of flooding, but have negatively impacted telecommunications and subsequently safer delivery and access to healthcare. Operating rooms have certainly been affected, as safe surgical care should not be delivered in damaged or less than ideal environments. As nearly 1/3 of global disease is attributed to surgically treatable conditions, access to safe operating rooms is critical. Extreme weather events have led to halts or delays in pharmaceutical and device production, leading to a lack of access of drugs and supplies necessary for surgical patients and surgeries. Climate change, causing extreme weather events, can negatively affect access to food and food production, contributing to nutritional deficits and subsequent poor wound healing, which is detrimental to the success of surgical operations. Additionally, excessive heat caused by climate change increases the number of violent crimes, thereby increasing hospital emergency department visits and traumas, and subsequently surgical volumes. This can be devastating to populations already affected by disparities and a lack of access to adequate health care. It's time clinicians think of work in the sustainability sector as not an extra, but as a necessary part of our practice to maintain public health. Physicians have an ethical obligation to protect health. We're generally governed by 4 ethical principles. Beneficence are the actions carried out to promote the well-being of others. Non-malfeasance, commonly known as first do no harm. Justice, and autonomy and respect. We must recognize that people living in a healthy environment will be healthier people and integrate sustainability practices into our fabrics. But it seems as though the very thing we're trying to protect and improve, health, is negatively affected by how we deliver healthcare in our buildings and day-to-day operations. Healthcare facilities are the second most energy-intensive commercial buildings behind only food service. The healthcare system accounts for 9% of US commercial energy expenditure and is the second leading cause of waste in the United States. US healthcare systems account for 8 to 10% of greenhouse gas emissions, which significantly impacts climate change and subsequently health. The operating room, or ORs, account for 20 to 40% of hospital waste. Up to 70% of water used during surgical scrubbing can be wasted. Excessive waste generation, improper disposal, and consumption of energy and national resources have significant negative effects on the environment. As an industry, we need to acknowledge that our operations impact our health and our community and the health of our patients. In everything we do, we must be deliberate in aligning our actions with the mission of healthcare sustainability, especially in how we build, maintain, and operate our facilities, so that we create healthy environments in which to work and heal. A recent Lancet study on carbon footprinting, focusing on 3 large healthcare systems in the United States, Canada, and the UK, found that anesthetic gases and energy consumption are the largest sources of greenhouse gas emissions in operating rooms. They found a 10-fold increase in gas emissions when desflurane was preferentially used, and this is known to be a primary contributor to global anesthetic gas emissions. ORs are 3 to 6 times more energy intensive than hospitals as a whole. This is generally attributed to HVAC systems. HVAC is responsible for 52% of energy needs in inpatient healthcare facilities and 90 to 99% of overall OR energy use, at least was found in this study. So what can we do? We should focus on balancing our carbon emissions with our carbon savings or offsets and aim to achieve carbon neutrality, like the Kaiser system recently did, and this is the first healthcare system in the US to achieve carbon neutrality. We should focus on interventions to reduce environmental costs and the cost of surgery. We need better processes for managing and minimizing OR waste. We need to focus on scavenging and minimizing anesthetic gases, especially desflurane. We need to preferentially use alternative anesthetic agents like regional or IV anesthesia. We need to develop renewable sources of electricity in operating rooms and hospitals. We need to focus on occupancy-based HVAC settings. We need to focus on environmentally sustainable purchasing practices. We should develop similar protocols to enhance recovery after surgery, or ARAS, which has streamlined and improved recovery after many surgical operations. We need to integrate and standardize best practices for OR personnel, including anesthesia, surgery, nursing, technologists, and other perioperative care professionals. We need to create metrics and measurements for OR and environmental sustainability and performance. And most of all, we need to increase awareness and invest in education. As one of the largest healthcare systems in the country, Cleveland Clinic has been committed to greening practices for well over a decade. Our brief list of operating room-based accomplishments includes energy conservation through OR setbacks, which has resulted in over $2 million in cost savings, LED lighting, which increases surgeon comfort and saves 60% of energy use, red bag or regulated medical waste reduction, plastics recycling, and our program has diverted nearly 500 tons from landfills, water reduction, particularly at the scrub sink, single-use device reprocessing, elimination of desflurane from our formulary, and this has significantly reduced our carbon footprint. But perhaps one of our single greatest and most unique achievements is the development of a healthcare sustainability fellowship, honoring a former Cleveland Clinic surgeon who died of pancreatic cancer and was passionate about the effects of OR waste on climate change. Every year, one general surgery resident who's interested in healthcare sustainability is selected. We sponsor yearly grand rounds, which are focused on healthcare sustainability and bring nationally and internationally renowned champions to educate our surgeons. Our surgical fellows have a yearly project focusing on many different things. A few have included OR water reduction, regulated medical waste reduction, sterile processing, and instrument waste reduction, energy consumption. These are all physician-led initiatives, and they're made successful through partnerships with multidisciplinary teams, collaboration with our Greening the OR committees, leadership of our sustainability offices, donations and grants, and high-level administrative support. In this fellowship, we have successfully championed plastics recycling, water reduction, regulated medical waste reduction, among others that I've mentioned, and many others that are unmentioned, and substantially reduced the negative impacts of the operating room on climate change and public health in our community. This is why I believe the true future of climate change and surgery rests on the shoulders of all of us, but particularly the next generation of clinicians. Integrating healthcare sustainability into the fabric of their learning is no longer optional, it's mandatory. We in the next generation must understand that climate change negatively affects public health. Healthcare systems are significant contributors. ORs are significant sources of emissions. Educating and engaging all clinicians, especially our future generations, is critical. It's the moral imperative of clinicians to act on climate change and have sustainably driven medical practices. Most importantly, we must stay positive and know that we can change this. Thank you.
Thank you very much to everyone who was able to pre-record those videos, and we are going to be joined now by Drs. Ilyssa Gordon and Dr. Rothenberg. So if you have questions, please be sure to put them in the chat box. My first question to Dr. Gordon is, COVID-19 really brought out some innovative ways to reprocess what was once thought of as single-use items like N95 masks. Have any innovative reprocessing techniques been used in the labs or come about because of COVID-19 or other natural disasters in other areas that are able to be shared with other healthcare organizations to create these opportunities for reprocessing? Oh, you're muted.
Thank you. That's a great question. Yes, the fact that we were able to reprocess N95 masks is certainly a win for our sustainability efforts overall. And in my area of interest, which is landfill diversion and laboratory waste, it certainly helps with that concept of what's called the ick factor that a lot of people outside of healthcare feel that anything that's been in the hospital that you're throwing away is potentially infectious, and that's not the case. We have special lines of waste in the red bag, biohazard bags for potentially infectious materials. And the concept just in general that we could re-sterilize the masks is amazing and helps us overcome this false idea that that everything needs to be thrown away and maybe infectious. So that's certainly a win. In terms of other things like this in the laboratory at this time, there's not any that I know of. There is one from the operating rooms, which is that there's a material called sterilization blue wrap. And this is collected at many hospitals across the country, and there's companies that are involved in recycling and reprocessing this material. We at the Cleveland Clinic, and I've heard of other healthcare organizations doing this as well, were able to collect the blue wrap and make it into masks, which have a decent level of protection, not quite as much as an N95 mask, but have a decent level of protection as as comparative to a cloth mask, or even better, against infectious agents. So I think just the overall concept that this is possible is really big for us at this time. One other thing that I like to mention about messaging and stuff in these times regarding laboratory type of waste or hospital type of waste is the fact that very early on in this pandemic, people were considering hand washing and considering hand washing or wearing gloves. So I think the message has certainly gotten out there that we don't see a whole bunch of people wearing latex gloves, which would contribute to a lot of extra landfill of that particular item, and that the public health experts agree that hand washing and sanitizing your hands frequently is the best way to protect your hands from infectious agents that may be on surfaces. So I think that avoidance of a potential need for increased use of gloves in the general population is also a positive.
Thank you for that. So we have a question in the chat box, and I believe this is for you as well, Dr. Gordon. Mm-hmm. How can manufacturers or distributors work with peri-op teams to develop more sustainable products for healthcare teams to purchase? What metrics of a product being sustainable are interesting for clinicians in considering a purchase?
Okay, those are all very good questions. So for the first part of the question, in terms of working together with manufacturers, We at the Cleveland Clinic are members of a group called the Healthcare Plastics Recycling Council, and within that group, there's representatives from healthcare organizations like ourselves, and there's also sustainability directors and packaging engineers and folks like that from medical device companies and other healthcare companies, such as like Johnson & Johnson and Medtronic, just to name a few. The idea of, for me, it's been extremely powerful to be just sitting in the same room back before we had to do everything virtually, but sitting in the same room and having conversations with these folks who are designing the packaging and the devices, and understanding really their perspective on what are the obstacles they face, what are the challenges that we would like them to overcome. And so it's just so helpful to have groups like that where we could be in the same room together. And then also through my work in the laboratories, I work with the International Institute for Sustainable Laboratories, and we also through them have connections with manufacturers of laboratory products. So we're able to have open lines of communication, and that's really what's important, is getting the right people connected in the same room to talk about it. What our issues are. Somebody could say, oh, we made this great compostable, packaging or whatever, but, not every hospital has composting, and maybe they do have a plastic recycling program or whatnot. And the other part of it about, I think the second half of the question was more of a supply chain question. What components are important? We are still assessing that. There's group purchasing organizations that are starting to have benchmarking and criteria about what they're able to call green. And so each individual healthcare organization would sort of need to identify what their sustainable purchasing goals are in terms of which characteristics of a product that they're most looking for. For example, does it contain any PVC or not? If you're trying to be PVC free, mercury, if you're trying to be mercury free, does it, has it been redesigned for less packaging, if that's something that you're going for, styrofoam or expanded polystyrene use, and that sort of stuff in packaging. You can look for those characteristics. Through my work in the laboratories as well, there's an organization called My Green Labs, and they have developed a third-party certified sort of eco label, which there's many dozens of these types of labels out there, as you all well know. But this one's called Accountability, Consistency, and Transparency, or the ACT label. And this is specifically, again, working with manufacturers and suppliers of laboratory products, which are a lot of the same companies that handle all of the hospital products, to give them a third-party verified sort of eco-nutrition label. So this is new and up and coming in terms of the group purchasing organizations doing this, and the ACT label being applied to many more products. But yeah, we're starting to work on that communication and getting transparency about the products we use.
Thank you. That was really helpful. Just so everyone is aware, I have posted a link to the survey in the chat box. We do ask if you are able to please take the survey. Nurses, in order to receive your CNEs, you will have to take the survey because it will link to the CNE certificate once you complete. This next question is for Dr. Rothenberg. So there's an increased prevalence of eco-anxiety in children. How can pediatricians or family doctors address this with parents if they see the stressors for eco-anxiety? Dr. Rothenberg, if you're talking, you are muted. Well, I do not know. Dr. Rothenberg, you're still muted.
Oh, she's saying her microphone can't be linked.
Oh, no. I can send you this question in an email and I can forward it on. Does anybody else have any questions? Please put them in the chat box now. Okay, if there are no further questions, we will go ahead and end the session for today. Again, the survey is in the chat box, and our next live session will begin at 5 p.m. Have a wonderful afternoon, everyone.